Tackle Talk, the men's health podcast. Three guys tackling all things men's health head on.
This is the next installment of the Ask a Urologist podcast. And this is a special podcast because we've got a couple of guests that haven't been on the show before. And I'd like to welcome Addie Lambo. Hi, Addie.
Hi, Andrew.
How you going?
I'm good, thank you. Very excited to be here.
And my good colleague and fellow urologist, Shane Bianca. Hi, Shane.
Hi, Andrew. Yeah, hi, Andrew. Hi, Addie.
It's
good to be here, finally.
Yeah, it's good. Now, look, I think we have to address the elephant in the room a little bit here.
It's a bit mean, isn't it?
The Kenyan elephant, in fact.
Or
would you rather be a rhinoceros?
Not even Kenyan.
Oh, you're not Kenyan. Somalian? Nigerian?
Yeah.
I think it's a myth.
But, I mean, there's two urologists on this podcast.
Yeah.
But there's
one real doctor.
One real doctor.
Yeah.
I'm not going to go through the banter of whether you should call yourself a doctor or not.
Please don't.
Just don't go calling yourself a doctor on an aeroplane.
No, I've made that mistake.
Exactly.
I've made that mistake once, and I'm never going to do that again. But yeah, so yeah.
So why would somebody whose main topic of research be coral and seagrass is interested in male genitalia?
Oh, that's a good question, Andrew. I guess I've got male genitalia, so inherently I think it's something I'd be interested in. But primarily I'm just interested in learning about new things, and you know, you're a good friend of mine, and I thought this would be a great way to spend an evening.
Oh, that's nice.
Talking about penises.
Well, you do bring some sort of veneer of professionalism to this because you actually have done a podcast before.
Very thin veneer. I do, yeah. I've done several actually, yes.
Well, that's like 1,000% more than us. So, welcome.
We're off to a good start already. So
you're going to bring the quality and the lay person's perspective on what is, admittedly, like, you know, the dark corners of medicine where a lot of people just don't want to go.
Yes, that's right. Exactly.
So
exactly right.
So last time on our podcast, we talked with my colleague Trenton Barrett about vasectomies, and I'm sure that was provided a lot of great information. But today we're really getting a little bit up close and personal because we're talking about a condition called Peyronie's disease, which for people who are not aware of that what is it, Shane?
It's really unfortunate when it happens because it's a bent penis or a curved penis that doesn't go where you want it to go.
And it's pretty common, isn't it?
It actually is, and I think part of the reason why we're seeing it now is because GPs are asking questions to patients about sexual function. There's a lot of guys who've had treatments for other conditions where one of the side effects is sexual dysfunction, so it's something that's sort of brought up in the follow-up conversations with their treating doctors. And I think younger guys are generally a bit more comfortable talking about stuff like this with their doctor because they're perhaps a little bit more aware of what, rightly or wrongly, is normal based on media, YouTube and other, sites, I guess.
It's one of those conditions where I'm sure it's underreported because it must be, men, it must get pretty bad for men to go to their doctor about it. It's an embarrassing sort of problem.
Yeah, I think it is. I mean, whenever a patient says to me, is this common? Because they think they're the only person who's got it because, of course, they haven't talked about it with their mates because they just don't. I say to them, yeah, well, look, it's a big part of my practice, and I'd estimate it's probably around 10% of the male population
really
have an issue with curvature and angulation. Whether that's actually clinically significant, for some it may, and for some it may not be.
Because it's not usually the sort of thing you sit around and talk about. I mean, Addie, do you sit around and talk about that with your mates?
I wouldn't know ordinarily, but if my penis was bent to the point where it was actually causing me to sort of for it not to function in the way I was.
We're
hoping.
talking like a horseshoe.
Yeah,
have you seen that? I mean, that's how bad it can get.
Yeah, absolutely. Turn back on itself. Exactly right.
I mean, that's my point. So if it was that bent, surely it would be sort of beyond the issue of embarrassment. You would just be compelled to go speak to your doctor because you wouldn't be able to function. I mean,
yes.
So I would imagine. I would imagine that the perhaps the cases that are perhaps underreported are sort of slight curvatures. I don't know. Is that the case? If you have a really, really bent penis, surely you're going to your GP.
Well, they're coming, aren't they, Shane, because there's some problem with the function.
Yeah, that's right.
Yeah, exactly. Yeah, and look, some of them do. I've had a lot of guys who turn up, and I ask them when did they first notice it, and they say it came on suddenly. And the guy's got a penis that's bent in a horseshoe, touching his belly button. You kind of think, well, that couldn't have just happened overnight. But some of them do, I guess, not want to take notice of minor curvature, and then you kind of get used to it, I guess, and it probably has to get to a point where it stops it from working for your partner before you think there's a problem with my penis. I suspect some of them are kind of in a bit of denial before they get to that point. And of course, there's the other thing too, is that, I don't think really most men know what a normal penis looks like, because really the sort of the urban myth, the social myths about what a penis should look like are based on the pornography industry. The normal penis isn't really out there unless you're sort of in the medical field, if you know what I mean.
So we've talked about what it is. What would you say is like a normally acceptable curvature angulation of an erect penis?
Yeah, that's a good question, isn't it? Because, what is normal? I think you've got to look at it from the point of view of reflecting back on function. Normal is whatever allows you to penetrate comfortably for both you and your partner. And that depends, because if you have a heterosexual relationship, a curvature, let's say up to 30 or 40 degrees upwards, for example, might actually not make much of a difference at all because of the shape of the orifice you're putting it in. Let's make an assumption you're having vaginal sex. The vagina's got a certain shape that can accommodate varying widths and lengths and that of the penis. So that could be fine. But I've got patients who are at the other end of the spectrum, are homosexual, and anal intercourse is important for them. And for those guys, to a certain extent, any degree of curvature is kind of really difficult. So if you take everyone, I normally say that anything up to about 30 degrees is probably functionally tolerable for most purposes.
Can I just jump in here, Andrew?
Yeah.
Shane, what about, putting sort of intercourse to one side, what about just urination? I mean, there's other functions that, you need your penis for, you use your penis for. What about just going to the loo?
Yeah, it probably doesn't have that much of an impact, except in two circumstances. And one of them would be guys who've got Peyronies who have a lot of shortening, who might still have a foreskin, for example. And then all of a sudden, as they're getting older, they realise their foreskin's getting longer, their penis is harder to find, and they struggle to actually get it out and pee. That's the first scenario. And the second scenario is the guy who's got quite significant curvature, that when he wakes up in the morning and wants to go for a pee and he's got a bit of a hard-on, he actually finds it difficult to have a pee because he kind of can't pee through a semi-erect penis because it's pointing up to his left shoulder, if you know what I mean.
Yeah.
So urination usually isn't a big issue, but in those two circumstances, it can actually be a problem. And I've had patients complain about that. Well, certainly the shortening one is a big factor.
This kind of goes back to my background reading, which I did for this podcast. You'll be glad to hear. Is that, let's talk about why this is called Peyronie's disease.
Yeah.
Peyronie was Francois de la Peyronie, Francois
De la
Guizot
Peyronie.
de la Peyronie, and he was the
That's right.
physician to Louis XV, who was one of the longest-serving
That's right.
kings of France. And he became quite an interesting guy, actually. He became a surgeon at a very young age, at the age of 17.
Wow.
And back in those days, you may already know this, Eddie, but
Is that when surgeons were basically...
they were a bit basic.
Butchers?
They were surgeons and barbers.
That's
It was
right.
the surgeons and barbers,
Yeah,
and
yeah.
and the reason why, and being a surgeon really meant just sawing off people's limbs when they became infected or, from military injuries.
Leeches.
And the reason why barber poles are that red and white diagonal stripes is because that's how they used to dry the bloodied bandages. They'd wrap them around a pole outside, so that's when you knew that was the surgeon barber's workshop.
Yeah.
But this guy was he was one of the first people to actually, in France at least, Peyronie was one of the first people to approach surgery as a field of medicine. So it wasn't really associated with the medical field or the scientific field. It was real sort of
Science.
It was a trade, really. Like you basically hacked people's limbs off, and no joke, he developed an obsession with phalluses. Now, it might be part of being a doctor in the French court, and we all know they were outrageous pervs.
Yes.
Those guys, they were basically, very, very into their sexual activities and
absolutely, yeah.
And
sex was a big thing, and so was syphilis.
And, you can imagine that one day, maybe Louis or one of his courtiers said, "Hey, Francois, hey Doc, we've got a little problem down below. You mind taking a look?"
Yeah.
And he actually described it as a disorder of ejaculation. So it was when it got so bad, the fibrosis got so bad, and we'll talk about what the actual cause of the condition is. It got so bad that it was blocking ejaculation, and that's what this first patient presented to him with.
Yeah.
And so he
must have had a pretty severe plaque.
Well, he examined these people, and then some of them died, and he actually did autopsies on them and described in quite a lot of detail, anatomical, scientific detail, the actual problem. So what actually is happening to cause this, Shane?
Well, aside from that acute problem that prevents you from having a pee or ejaculating properly, essentially you've got imagine you've got, what I say to patients is, imagine you've got a pair of sausages, and the skin of the sausage is keeping the inside in a particular shape when blood fills that. And with Peyronie's disease, the skin is abnormal in areas that cause it to thicken and scar. And when you get an erection, it tends to bend in the direction of that scar. It's a bit like when you cook sausages and they curve. Hasn't you ever noticed how when you always put sausages on the barbecue and they're straight, and they always curve, don't they?
Yeah, they do.
Yeah, that's because if they've got natural skin, so if they've got intestinal skins as opposed to artificial skin, then along one edge there's a thicker band where the blood vessels would attach to the gut, and that bit contracts more than the rest of the sausage skin does, and therefore they bend towards that.
But just to be
so it's
clear,
exactly the same principle.
When we're talking about the skin, we're not talking about the skin of the penis. We're talking about
not talking about the skin. That's right. We're talking about the internal.
Yeah.
That's right. Yeah. It's almost like a casing on the inside. That's right. Yeah.
So the structure, if you took a cross section across the penis, God forbid, would be there's two big cylinders, which are the cavernosal bodies, which are the erectile tissue, and then there's one tube running below them in the midline, which is the urethra, which carries the urine and the semen. So what's covering those? What's encasing those tubular structures?
Yeah. So you've got on one surface you've got lots of nerves and blood vessels, and you've got another layer of what we call connective tissue, which is kind of like another sleeve, and then you've got the tissue beneath the skin, which is often a sort of thin fatty layer, and then you've got the skin. And Peyronie's is a disease process of both the casing of each of those cylinders, but also part of that surrounding sleeve, which is underneath the nerves and the blood vessels. And that's why when you see patients with Peyronie's, the nerves and the blood vessels in cross-section are sitting above the disease process. So
and there's
it's an important thing to...
Sorry, there's a similar disease process which happens along the tendon sheath in the hand, isn't there?
Yeah,
named after
exactly.
another
So
Frenchman called Dupuytron.
Yeah, it's Dupuytron.
It's a
That's
Dupuytron
right.
contracture or a trigger finger. Yeah.
That's right, yeah. So that's usually affecting your ring finger and your little finger, but it can affect all of them, but it tends to be the gripping fingers. And there's even a third condition, which is in the feet, called plantar fasciitis.
Oh, yes,
I
am aware of that one.
Yeah.
Runners.
Yeah. So they're all conditions of connective tissue that is designed to be extremely tough, but very flexible. And the abnormality in sort of pathophysiological terms is a failure of the healing process within that tissue after an injury to re-establish the same structures that were there before, namely a strong but flexible tendon in the case of your feet, sheath in the case of the hands, and corporal tunica in the case of the penis. So what then happens is you get dysfunctional healing and scar tissue forming that distorts the natural stretch of that tissue.
Well, so Shane, what actually causes this? So we've talked about sort of what it could look like and a bit of the anatomy components, but how does it happen?
Yeah, well, most patients don't report a injury, but there's two theories. One is the theory of macro trauma, which is where patients will have an injury of some sort, where they've basically fractured the penis. So that casing is put under extreme tension when the penis is erect or semi-erect, and that casing cracks, which means it ruptures, and then you get traumatic healing and scar tissue forming. But the other theory is that it occurs as a result of gradual loss of erectile rigidity as we age, related to multiple conditions such as diabetes, heart disease, vascular disease. And those situations are where the erection is not 100%, which means it suffers some sort of distortion, twisting, concertinaing, or bending that leads to micro tears in the tunica. And then as that tries to heal, it doesn't heal properly because the underlying disease process is what caused the erectile dysfunction in the first place. And so then when it heals with scarring, which then exacerbates the primary cause. And that's why we often see erectile dysfunction at the same time as Peyronie's. It's sometimes you'll see a guy who comes in with a strong erection and it's just got a bend, but then you'll see more often than not, I see guys who've got a degree of erectile dysfunction as well as a bend.
Okay.
Yeah, then it becomes a bit difficult to figure out which is causing which.
Yeah, that's right. Yeah. It's that sort of from a pathological or pathophysiological perspective, it is a bit of a curiosity as to which one's first and which is second. But from a practical treatment point of view, it's sort of less of a problem because you treat both conditions in the same way with the same medication as a general rule, and so you fix one to try and help the other.
Okay.
And that's why surgery isn't the first thing we think about when we see a guy with Peyronie's disease.
Yeah. All right. Well, I think that's quite a good point to take a little break. And when we come back, we're going to go through the various phases of presentation of Peyronie's disease and just what we can do to treat it. So stay tuned.
Tackle Talk, a men's health podcast, is proudly supported by Perth Urology Clinic, Western Australia's largest urology practice.
All right, so we're back on the Ask a Urologist podcast talking about Peyronie's disease. And you've got two urologists plus someone who's interested in talking about Peyronie's disease. And just before the break, we covered the perversities of the 18th century French imperial court. We talked about the pathophysiology of this condition and how it's related to the anatomy. But Shane, just from a practical point of view, what's the typical guy who presents with this disease? What does he look like and what does he complain of?
He's about 50-something. He's a little bit overweight. He may or may not have been a smoker. and he's presenting with change in the shape of his penis that has finally got to the point where he and his partner are not sort of able to have sex easily. But there's a spectrum, really, isn't there? I mean, I've seen 20-year-old guys come in with it, and I've seen 75-year-old guys come in with it. I've seen patients come in with severe pain in their penis when they get an erection, but nothing in the way of a deformity or a change in the shape. And I've seen guys who present with very significant shortening of the penis and scar tissue that's almost turned into bone and prevents them from being able to get an erection because it's stopping their penis from stretching. So if you think of inflammation as a disease process, then inflammation has certain phases. So it often will have a painful phase, which then changes into a phase where there's deposition of inflammatory tissue and swelling, and then you get this sort of gradual move towards resolution of that and replacement with slow or chronic inflammation and scar tissue. And that's common for a lot of different organs, and the penis is no different. So, I'll often have a patient who comes in, and they come in with a bend, but when I ask them the history, they say, 12 months ago I started getting erections that were painful, and I'd wake up at night or in the morning and it'd be really sore. And then I noticed a little bit of a lump, and the lump wasn't painful, but it was just sort of a bit tender to touch. And then all of a sudden it started changing shape and it became more bent and funny, and I got to this point. So there's a lot of variation in how men present, and each of those phases, if you like, can vary in time. So patients can have pain for a few weeks up to several months. Even I've had patients who've had it for 1 or 2 years before they finally then had a change in the physical shape or alteration in the features of the penis.
And how does the way that you treat them or approach them differ based on the phase of their presentation? So for someone who's coming in where there's a short history and there's still a lot of pain and tenderness, and they think that the curvature is getting worse, versus someone who said, it's been like this for 2 years and it hasn't really got any worse. I'm just sick of it.
Yeah, it's managing expectations is the most important thing, because obviously they'll have two different perspectives on what they want to achieve. The guys who've got painful erections, they want the pain to go away so they can still have sex. And part of the problem, of course, is if they continue to have pain, then they don't have sex, which means they don't have as regular an erection. And if they don't have as regular an erection, then the underlying process can potentially be facilitated, because, well, what happens when you have an erection? Your penis stretches, doesn't it? So it's its own natural sort of physiotherapy. And if you're not getting erections, then you don't get that stretching process. So any inflammation that leads onto a scar in the absence of regular good erections will tend to be exacerbated. So
the goals of therapy are to maintain function and alleviate symptoms. And is there anything you can do to sort of arrest the process or stop it getting worse? So what sort of tools do you have at your disposal there?
Yeah, we've got there's a lot of things you can do, and they all kind of go back to the same principle, which is maintaining as normal as possible a physiological sort of erectile pathway. So I say to patients, and I say to guys, and I say to their partners, look, the erections might not be too bad, but the underlying process is related to the way the erectile tissue and the penis functions. So the first thing we have to make sure is that you are facilitating or promoting the best possible erection you can have. So if you're a smoker, that means stopping smoking. If you drink too much, it means cutting back on alcohol. If you're a diabetic who's got poor diabetes control, it means start focusing on your diabetes. So they're general things. Then you look at, well, how do you make your erections better? And there's two types of erections. There's your erections that happen at night that are just sort of physiological. And then there's the erections that happen when you get aroused. And you have far more nighttime sleep-related erections than you would normally have arousal erections in the 24-hour cycle. So I say to patients, look, taking a medication that's going to stimulate your nighttime erections at a sort of basic level is really important. So that's why we use medications like Viagra type drugs, but in very low doses, so that it helps to improve the nighttime physiological erections. And some of them also notice they get improvement in their daytime erection or arousal erection as well. And then if pain's a component, then treating the pain with both anti-inflammatories as well as simple analgesics like paracetamol. And then there's also medications that help to improve blood flow in the tissues of the penis, separate to the drugs like Viagra and that, which act on the specific erectile pathway. And they're drugs that simply open up blood vessels, and they're a different group as well. So it's really a combination of all of these things. And I generally will start patients with early Peyronies or evolving Peyronies on those medications to try and subvert or prevent the process from getting worse. And normally that's something that we try for 3 to 4 to 6 months to see if it helps.
That's great. Shane, would that be the same, that sort of treatment pathway that you just talked about there, would that be the same for someone who's also had that sort of initial trauma? You talked about 2 ways of this happening, that real trauma, be it an accident or something else. Is that the same type of treatment that you would suggest?
Yeah. In fact, it's probably even more important, isn't it? Because there you've got a definite cause and effect. And if you allow the natural healing processes to occur, given the underlying pathology, you're probably going to get a worse scar than if you try and promote better healing. And of course, if you've got a scar that's forming and the erections are not that frequent, then the penis is not stretching, which means it's staying in a sort of shortened, flaccid state. And when the scar forms, it tends to contract. So the theory goes, try and stretch the penis.
Yes, I've never heard of that. So erections as a form of physiotherapy. I love it. I'm gonna keep that in mind.
Yeah. Well, that every guy that I see who doesn't turn up with his partner, he says, "So do I need to have more sex?" And I say, "Yes, that's right. You need more erections."
Yes, well,
But Eddie, this doesn't mean you have to go down to the physiotherapy clinic with those young ladies and start talking about this. You'll get thrown out straight away.
I think I'm more liable to be arrested.
Exactly. Yes, we do not recommend that.
I've just never heard of an erection class as physiotherapy. It's fantastic.
Well, I mean, it's part of a normal physiological process.
Yeah, it makes sense. Particularly when Shane was talking about plantar fasciitis, which is something that I've had, a lot of runners do. And I never really thought about that in terms of the connective tissue getting pulled. So.
Well, that's right. Because, if you've got plantar fasciitis and you stop running, it'll probably heal up, but you'll then have a problem when you start running again.
Yeah, it's terrible. Yeah, exactly. And exactly accurate. Yeah.
Right. Yeah, I mean, in all other phases of rehab where you've got the risk of scar tissue and contraction of fibrous tissue taking place, the rehab aims to stretch it out and prevent those contractions from happening. So it's just another part of the body that has collagen, basically. That's what we have to think about it as.
Exactly right.
So let's move on. So you've treated this guy in the acute phase. You've given him some like Viagra or Cialis type medication. These are called PDE5 or phosphodiesterase 5 inhibitors. They promote the release of a compound called nitric oxide, which improves endothelial or blood vessel relaxation, allows oxygenated blood to go through, flushes out the deoxygenated blood. All of that's important in combating inflammation and anti-inflammatory effect. What about anti-inflammatory drugs, analgesics? Do they have a role?
I think so, yeah. Well, especially if someone's got pain, I think that's really important. Whether someone needs anti-inflammatories if they don't have pain is debatable. I think I usually suggest that rather than taking an anti-inflammatory, which is fairly potent and has potential side effects in terms of gastritis and peptic ulcer disease, I usually say to patients, if they don't have acute pain, that one of the sort of supplements that might assist with the healing process is something like curcumin or turmeric. It's been used a lot in Eastern Ayurvedic medicine for many, many centuries. It has, that's the one, yeah, Ayurvedic. I always get stuck on that one.
I thought that was good.
But I think it's yeah.
But I think it's into his complementary therapies.
Very much so.
Hot yoga.
But I think it's probably something that can be easily taken and probably has benefits beyond just Peyronie's disease in terms of systemic anti-inflammation, but it also might have some anti-fibrotic effects, and it may even have some analgesic effects. So it's quite a good supplement with very few harmful side effects, except if you can't tolerate curry particularly well, and that might be a bit hard on your stomach. But
shame.
Aside from that,
everybody should be eating curry. Turmeric tastes great. Everybody, come on in. Everyone should be eating curry. It's my favourite meal.
Yeah,
my wife will tell you that. She
and
says,
then
curry again.
Yeah. And then as well as turmeric or curcumin, there's also some other supplements that you can throw into the mix. And one of them is acetylcarnitine, which is an antioxidant, going on the principle of free radicals that are harmful in the sort of deoxygenated blood that sits in the penis when it's not actively erect. So taking an antioxidant may help. And certainly when you look at the studies that have been done on drugs for Peyronie's disease, acetylcarnitine, curcumin, and another one called L-arginine, which is very similar to Cialis and Viagra, they've been shown to have some potential beneficial effect. So, nothing better than saying to someone, I want you to take drugs, but I also want you to take supplements, because they kind of think that you're really sort of, on the ball with, complementary medicine.
Yeah, you're a real holistic practitioner. Got all the
That's right,
medicine fans out there very excited.
Yeah.
What about vitamin E? I used to believe that had some scientific evidence behind it.
Yeah, look, vitamin E is an interesting one. So theoretically, vitamin E has antioxidant effects, so that's why you take it. But the problem is, there's not that many good studies that have shown that it has a significant benefit. And one of the problems is the dosing. We don't really know what dose to give in terms of vitamin E. Vitamin E creams have been tried. Topical vitamin E, again, the absorption's variable. We don't know if it actually gets into where it needs to go. I'm not a big fan of it, but if someone says they want to take vitamin E, I say go for it. It's an antioxidant, so theoretically, yep, same theory. It just hasn't been studied quite as well as the other ones. And there are certainly a few other things that have been tried in terms of medications, and not just tablets. There have been a few other sort of injections that have been trialled, external physical therapies that have been trialled. So there's a lot of stuff out there, but the data is not robust insofar as good evidence to show that it makes a big difference. And I'm talking about things like shockwave shockwave therapy, injection therapy with anything but one particular drug. We'll get onto that later. And vacuum devices that just stretch the penis. There's limited evidence that they work well in this particular situation, Peyronie's disease.
Yeah. So I guess the other side of things is the psychological effect of this condition, and it's going to make guys pretty anxious and depressed. So in that acute phase, what sort of things do you tell them? Do you give them a bit of a sense of perspective and hope, I guess, in terms of how many people are actually going to stabilize and improve over time versus people that will need to go on to the next phase, which we'll talk about in a second.
Yeah. I would estimate that about a third of them get some response to all of the oral therapies. So that means that they get some response that gets them back to a functional shape that allows them to perform. And about a third sort of don't change much from when you see them, and that may well be that group that have sort of have got through the process, if you like, and they're at the end of the line, so nothing's changing. There's no active disease. It's just solidified. And then you've got those guys, unfortunately, who are at the very early sort of phase of an aggressive inflammatory process, and they don't respond very well, and they can be really difficult. They can have migratory plaques, or they feel the lump one day in one spot, then the next day in another. Their penis goes from being bent upwards to bent downwards. Their erections come and go. So there are some guys who've got really bad erectile disease that's adding to the Peyronies, and they can be really hard to treat because they're very despondent because it's getting worse despite what you're doing, and they're hard to deal with. The other guys you can kind of cajole along and you can encourage them, and most of them will see some improvement. And if they don't see an improvement, it doesn't get worse. So at least that's good.
Yeah.
But it can be tough because especially the younger guys, the guys who are coming in their 20s and 30s who thought they were normal, and all of a sudden their penis is just doing strange things on its own.
We're going to talk about now the most difficult types of cases that Shane comes across, and these are the ones that develop quite significant deformities which are causing significant functional problems. So, Shane, how do these present?
Yeah, well, look, there's quite a number of them. It's probably the easiest way for me to talk about them is perhaps present a couple of individual cases because they do represent the sort of the spectrum. One of them's a 20-something-year-old engineer who presented with Peyronie's disease and sort of multiple nodules in his penile shaft that were causing his penis to essentially be wonky in multiple directions. And his disease wasn't stable at all despite medication. He was I saw him at sort of monthly intervals, and he was basically getting plaques that were developing and then disappearing and developing and disappearing. And really, each one of them was really painful. And we tried pretty much everything with him. And in the end, the underlying problem that he had was that he had a failure of the normal mechanism of his erection, such that the tissues of his penis were not normal. And he eventually came to have a penile prosthesis put in to try and essentially prevent his penis from continuing down this pathway, because eventually what would have happened is it would have just scarred down into a sort of very abnormal sort of erectile tissue length. And he's had a penile implant put in, and effectively what that's done is it's taken away his natural erections, but it's stabilised his penis in terms of shape. And so he now has a penile implant inside the penis which keeps it at the same length, and he mechanically pumps his penis and it works really well. So that's a sort of if you like, one of the severe inflammatory cases, if you like.
Maybe we should just briefly describe for our listeners and Eddie, who's looking very perplexed, what a penile implant is.
I'm glad you picked that up, Andrew, because I was just about to ask what is a penile implant.
Okay, so you think of implants, and the first thing that people think about when they think of implants, they think of breast implants, okay? So a breast implant is placed inside the breast tissue to recreate the shape of a natural breast, albeit a little bit larger than what was in there before. And it's made of silicone and it's filled with a fluid. So you can also put implants elsewhere. For example, you can put a artificial hip in, and the artificial hip replaces the bone of a normal hip joint. So it's got a socket and it's got a ball on the end of a stem, and that replaces the natural anatomy of the hip joint. And all of these things work like the organ they were meant to be before. They're not perfect, but they work very similar like that and give it function back. And so a penile implant is a hydraulic device that essentially sits inside the natural hydraulic or blood vessel tissue of the penis. So if you can imagine, we talked before about the whole idea of the two sort of sausages of the penis. Well, if you can imagine that inside those sausages you put a silicon cylinder that fills up with water, expands in a little bit of length and girth to create the same sort of shape as a penis. And that's connected to tubing that allows you to take water from a reservoir, put it into the cylinders and pump it back out when you've finished with your erection. So it's a penile implant that replicates the hydraulic function of the penis. It's fully enclosed inside the body, and guys basically reach down to the pump, which is sitting in the scrotum. They squeeze on the pump as if they were squeezing on one testicle, but they're squeezing on the pump, and the pump moves the water around.
And does that water just go around? That's like a closed circuit?
Yep.
Shane,
Closed circuit, yep.
Doesn't ever need to be flushed or anything like that?
No, it's closed circuit. Wow. The body seals it off, and it stays there for as long as the implant material retains its integrity, which is variable depending on how much you use it. But normally we say to patients it's something between sort of 5 to 12 years, depending on how often they're having sex, basically.
Is that like just a saline or something?
Yeah, it's a saline-filled cylinder, basically, yeah.
Yeah, wow. That's incredible.
Yeah. So this probably deserves a podcast all its own. But
how do you deflate it? So once you've pumped it up, how does it go down?
It's got a little deflate button. So it's got a pump that you squeeze the water mechanically, and then it's got a little button above, which is a valve, and you press the button, which reverses the valve flow and allows the penis to empty out.
Okay. Well, that's fascinating. So that was one of the examples. You said you had another. So that was a 27-year-old engineer. What about the other?
Yeah.
example?
Yeah. So another guy that I did recently was a guy who'd he'd been seeing doctors for a while about his Peyronie's disease, and I don't know what it was, but I don't think anyone had really examined him properly. And he kept on saying to them, "There's something there," and the doctors kept on saying to him, "Oh, you take this, take that," or saying, "Well, there's nothing you can do about it," blah, blah, blah. And he eventually came to see me, and when I examined him, he had quite a significant shortening of the penis because of all the scar tissue. But what he actually had in the top of the penis, beneath the nerves and the blood vessels, and not replacing, but almost within the natural tunica, the casing, was a bone, which was effectively bone that had formed within scar tissue over a long period of time. And this bone would have been about 6 centimetres long and about 2.5 centimetres wide as its maximum, shaped a little bit like an arrowhead.
What? So it wasn't just calcification, it was actual bone formation.
It was actual bone. Yeah, that's right.
You can
and that bone was... Yeah, and that's not unusual. Bone can form, It's what's called dystrophic ossification, and it occurs in unusual situations. Burns victims can get it, for example, in bad scars, but it can also form in, you hear about guys getting a corked thigh in footy or rugby. Yeah. And if that hematoma isn't treated properly and it doesn't break up, then the hematoma can eventually form into a fibrotic mass, and that fibrotic mass, if it's not able to be broken down, can eventually just form into a calcified or even ossified mass, and you can end up with a piece of bone.
Is this
and
like
that's the same process here?
Yeah, is that like stimulation of some stem cell, which then
it must be. Yeah, that's right.
Bone? We're getting a little bit
because often we'll find
that's what when people talk about stem cells, those are the cells which can form all different
lots
types
of different things.
Of tissues.
Yeah, exactly right. Yeah.
And
and so the solution for him was actually to dissect out or cut out that bone and then replace it with a graft material that would heal much slower and without the same underlying problem. And so he had that removed, and that's sort of one other extreme. And then the other one is the guys who've just got a really severe curvature. For example, the horseshoe penis, where it, when it's erect, it sort of goes out, comes back, and then touches back again. It sort of does a 180 degree.
Yeah.
Often with those guys, when we have to operate because there's nothing else you can do for them, what we can do is we can combine a combination of releasing the scar tissue on the top and pinching some skin or tissue, not skin, but the casing, if you like, on the underside. So you shorten it a little bit on the underside, but you loosen and release it on the top side. And that therefore allows you to get a penis that will be will be significantly straighter, albeit a bit shorter than what they had before. But a lot of these guys don't care about the length as long as they've got a functional penis, so long as it's long enough.
And if there is a concern about too much shortening, you can put grafts in, can't you?
Yeah, we can graft them. Grafting's a bit tricky though, because you've got to, in order to graft, you've got to put something in that's not going to undergo the same process that the tissues there underwent, which is fibrosis and scarring. But that kind of leads us on to the principles that you have to apply after you've done something like a graft, and that is, again, going back to the stretching side of things. And there are some devices that we can use that allow you to do that surgery, but then very quickly afterwards get the patients onto a a stretching program. So they're actually using a device to stretch the penis, which in addition to stretching the natural tissues, also stretches your graft material in the hope that when it does heal, it doesn't heal contracted.
That's the RestoreX device?
The RestoreX is one device. Yeah, exactly. Yeah, the RestoreX. There's a couple on the market, but the RestoreX is probably the one that's now being used more often because it does actually have quite good data supporting its use. Developed by a urologist called Landon Trost at the Mayo Clinic in the USA. And it's not just a stretching device because they've been around for a long time. This is a stretching device that allows you to shape the penis, whereas before you could only kind of like stretch it out in length using a cage system with pistons that allowed you to hold the end of the penis and sort of pull it away from the body. But this the RestoreX is different.
Eddie's pulling some funny faces here.
It sounds like some sort of medieval talk show. So when you said the stretching device, I thought because you talked earlier around a vacuum sort of device. No, that's what I thought.
Yeah, vacuum pumps. That's right.
That's not what this is, though. This is different from the vacuum pump.
No, that's right. Yeah. Okay. Vacuums are one thing. Then they have their role as well. But this is actually a specific physical stretching device that it's kind of like the rack for your penis, if you know what I mean.
Yeah.
But without the spiky bits.
And so, and do you keep it on? So what would be a normal regime for the RestoreX?
Yeah, the good thing about the RestoreX is because it's stretching, but also it's not just stretching it in length. You can also mold it or bend it against the natural curvature of the penis. So if you've got a penis that bends up, you can stretch it and then bend it in the opposite direction when it's flaccid.
Yeah.
So that you're putting maximum pressure on the contracted side. Yeah. And so you only need to wear it. The trials that were done suggested that 30 minutes a day for 12 weeks was effective. And so I say to guys, put it on before you go to bed, and just before you're sort of ready to go to sleep, you take it off. And I said, don't worry if you forget, because most of the time what happens is if you forget and you've left it on, once you go through your sleep cycles, once you get into REM sleep, you'll have an erection. That's what most guys do. And if you get an erection when this thing's on, you wake up because it becomes a bit uncomfortable because it's pulling against the mechanism. But it doesn't do any harm or hurt you, and you just take it off if that's the case.
Well, this begs the question, do you ever get anyone who doesn't present with the Peyronie's disease asking about RestoreX? Does that ever happen?
Yeah. So, in other words, they just want a bigger penis?
Well, I mean, I was just sort of doing
He's
the logic.
asking for a friend.
I was just doing the logic myself, and I thought, well, okay. Presumably that would happen?
Yeah, well, the short answer is yes.
Okay.
It does. You can stretch a normal penis. You can stretch a normal penis either using a vacuum pump or using something like a traction device like the RestoreX, and you will probably get some improvement in length of maybe 1 to 2 centimeters, depending on how much you use it.
But we are not recommending it for that use.
Correct.
And we take no responsibility for that's a off-label indication from our point of view. We certainly wouldn't.
Very much off-label.
Yeah, we're not promoting RestoreX as a penile lengthening device for people who are otherwise normal
with normal
penis.
Normal
I mean,
exactly right.
Potentially, if it was misused, you could cause damage to the fibrous coat of the penis and
numbness and damage to the end of the penis. Exactly right.
That's right, the nerves and the vessels. So all of this can potentially lead to trauma. So they need to be used for the correct indication and under supervision.
Can we just
absolutely
just those 4 cases that you presented? I mean, what were the prognoses? Or is that the right word? Prognosis. How do they go? How do they turn out?
Well, good. Yeah, really good. I mean, the young guy with the implants, he's done really well.
Okay.
I think 10 years down the track, I replaced it, and he's pretty happy with it.
Wow.
The other guy with the bone in his penis, I mean, he's done really well, and he's early on, and still, a lot of these guys have a lot of recovery and rehab in terms of nerve stimulation to get back to normal, because it's often a bit traumatized initially. But as a general rule, the key to surgery for this sort of thing is doing the surgery at the right time for the right patient for the right indication. Yeah, okay. That's a good principle.
But there's hope. There's hope from what you're saying.
Yeah, absolutely. Yeah. And often you'll get some unusual shapes. You might have a guy who, instead of having a bend, they might just have an hourglass deformity of the penis, whereby the sides of the penis are contracted. So when they get an erection, the end of the penis is full, the base of the penis is full, but in between it's kind of hollowed out or sort of almost like wearing a waistcoat. Yeah. And they can sometimes require a different type of surgical correction to try and correct that deformity. But it's still feasible. And the key goes back to making sure that these patients are on the right medications to ensure the correct environment to allow for the best healing and most effective development of normal tissues as a result of scarring that don't contract again. So whatever you do, you're always trying to improve their erections and making sure that the tissues heal in the best possible way.
Yeah. Now, Shane, in recent years, and perhaps they might have fallen out of favour recently, but there has been talk about injectable therapy to try and break up some of the scar tissue. What sort of role does that play these days?
In Australia, unfortunately, a small role because of availability. If you look at it worldwide, though, it's still quite a useful approach for those patients who've got simple plaque that hasn't yet formed into dense scar tissue, whereby, for example, the situation where I had the guy with the bone. So for those guys who've got a plaque that's causing a bend, then drugs like Xiaflex, which is an enzyme that breaks down collagen bonds, they can be very useful. But the problem in Australia is that those drugs are so expensive because they're no longer listed. So to give you an idea, you hear about drugs costing a lot of money for chemo, for immunotherapy, for strange cancers and stuff, but this is up there with it. It's about 4 treatments or 4 injections, which is what most men would need, and you're looking at between $40,000 and $50,000 because each injection is about 10 grand plus all the other costs involved in providing it. Goodness. So unfortunately, the health funds don't cover it, and we're limited. And it's a good drug. Unfortunately, it works, but it's just so unaffordable.
Yeah. And what are some of the risks with using it?
Yeah, and you've got to be careful with it. So what Xiaflex is an enzyme produced by flesh-eating bugs. So in the ground, you have a particular bacteria called Clostridium histolyticum, which essentially means a Clostridium like botulism Clostridium. But this one's called histolyticum because it actually breaks down protein. And the enzyme's called a collagenase because it actually breaks the bonds between collagen. So this is a bug that can break down meat and animal protein. And what they've done is extract it and isolate it and attenuate it so that it can be used as an injection into a collagen plaque. And if you think of a collagen plaque as a disorganized mass of collagen fibers that normally should be lined up alongside each other so that they can stretch in alignment, but in the plaque of Peyronie's disease, they're disorganized and they've essentially formed a knot. So if you inject into that with this drug, you can break up the crosslinks between all the collagen. And then by using a stretching device and manually manipulating the penis, for example, with something like the RestoreX, you're then molding the scar that's there back into a more physiological and functional alignment, which means it can then do what it's supposed to do, which is stretch once the penis gets an erection. And so, of course, if you inject it in the wrong spot, it's going to damage tissue elsewhere. So it's got to be injected into the plaque and only into the plaque. Otherwise, you can get bleeding. You can get really bad hematomas. You can get damage to healthy tunica tissue, which then becomes weak and might break. So you then have the problem of an area that can fracture. And it can also get into blood vessels, which means you can damage the blood vessels and potentially cause problems with what we call fistulas. You've got to be careful with it, but if it's used properly, it's a good drug. But it's the cost that really stops us from using it.
Yeah, interesting consent process, wouldn't it be? You say, sir, I'm going to inject some flesh-eating bacteria into your penis, and it'll cost you $40,000. Keen? I mean, inflatable penile prosthesis sounds like a breeze compared to that, doesn't it?
Yeah, well, that's the thing. And look, I've used it a fair bit when I was able to, and I was actually quite happy with the results. It's done properly and done carefully, it works really well. It's sad actually because it's been taken off the market in Australia for commercial reasons, and that means we can't get it.
Great. So if there is, like, say, milder, cases where there's just a bit of a deformity and perhaps it's causing a bit of discomfort either the patient or their partner. Is there any role for penile fillers in that instance, where you're just trying to smooth out the contour of the penis?
There's been talk about it, but it probably doesn't add much to the underlying problem, in that if you've got, for example, say you've got a divot on the side of your penis and it curves off to that side, you could technically put a filler in there to change the shape of it. But that filler is not going to provide any structural integrity to the penis, which means you're still going to have the weakness at that point, the potential flexibility at that point that's going to make it susceptible. So I think fillers can unfortunately give the impression from a cosmetic point of view that it looks much better, but that's not what we're aiming for, is it? We're not aiming for cosmetic cure, we're aiming for functional cure. Yeah. And that's really important. It's talking to patients about whatever it looks like, you've got to go back to how it functions. You may not like the way it looks, but if you and your partner are having sex and it's really good and you're enjoying it, and you get to orgasm and your erection lasts long enough and neither of you is sore, then that's what's meant to happen. Therefore, what are you trying to fix? Yeah. And so I think that's where it comes down to goals and expectations. It's really important.
Yeah, I think the role of those fillers seems to be very much aimed at the younger end of the population, where it's really they're quite obsessed about the outward appearance and not so much about the functional status.
That's exactly right.
Yeah.
Yep.
So, look, what types of operations you've talked about? Plaque excisions, about plication, where you're straightening it, and as we know, all surgery carries risks. So, what should patients know about the potential risks associated with those types of surgeries?
Well, maybe the best person to talk about to ask the question would be Adi, and then I can answer his questions. So maybe Adi should ask me what he would be worried about if he was having an operation on his penis.
Well, I guess I'd want to know, how long am I likely to be out of action, I guess.
I thought you were going to say something else there.
How long is it going to be afterwards?
Well, I think that's probably something, once you sort of talk to me through sort of the actual procedures and I've got a sense for the risk and the likely outcome, I think probably the first thing I'd want to know is, well, how long am I going to be out of action, Doc?
Yep. So I normally say to patients, you probably need to stay away from penetrative intercourse, which is where, if you think about the forces that are acting on the penis during penetration, that's where most of the pressure is going to be on the healing components of the repair. I normally say to guys about 4 weeks, but if there's any bruising or swelling or anything that might prevent you from getting a full erection and being able to do it normally, then you might want to leave it a bit longer. And I also say to patients that, if you're going to get back into having penetrative intercourse, you probably shouldn't be doing it the way you did it when the accident first happened. For example, if your partner was sitting on top and that's when you fractured your penis, maybe that's not a great position for you anymore, and you need to think about that in terms of the forces that are acting on the penis.
Less axial
so
loading.
I normally say, less axial loading, that's right. Or as one of our colleagues in Brazil talks about, torsional rigidity, which is really important in terms of how the penis stands up to pressures and forces acting on it.
What else did you want to know, Adi? Come on, this is your big chance.
This is my big chance. I think that's probably the other thing is that, once, in this scenario where you've actually had the surgery, assuming that I am sort of listening to your advice and not doing those things I shouldn't be doing, is there a chance of it just coming back on its own? Having to go through the procedure again.
Yeah. There's a chance of it coming back, but the chance of you having to go through the same procedure again is actually not that high. And the reason for that is that the reason it probably comes back is because you're progressing along a pathway towards erectile dysfunction and failure.
Okay.
So what that means is that the underlying erection problem is going to get worse, which then puts you at risk of developing the problem again. So in the event that that happens a second time, then we've got to go back to principles and say, well, what's the reason for this? How do we fix it? Can we fix it? And then we need to look at other options. So I'll have a lot of guys who've had surgery who then start to notice erection problems becoming the main issue. Yeah, so they just don't have a hard enough erection. And then we're talking about how do we fix that problem. So it's not so much the curvature that tends to be the issue, it's the erections. Some guys do get a recurrence. For example, if they've had a plication and the sutures break, then sometimes they can get a recurrence of it. But more often than not, they don't. Certainly not my experience. And I've had a few patients who've had a sort of unsatisfactory correction for their liking, which has necessitated a redo procedure. So it's not as though it's got worse or come back. It's simply not as good as that it needs to be for them to function. And I guess the thing about it is every time you operate in that area, you're going to potentially have the same set of risks to the blood vessels, the nerves, all those sorts of things. And then there's those issues with sensation afterwards and swelling and scarring that might then have an effect on the skin and sensitivity, etc.
Okay. And I suppose the two other things that we were always told to counsel patients about with the so-called Nesbitt's procedure or plication procedure, which patients are going to be concerned about, but they may not necessarily bring up. One is penile shortening, because no guy wants that. And the other one, I guess, is patient or partner discomfort or pain. So I think that's particularly relevant to when you're using sutures, and if they can feel something afterwards, it's going to bother them.
That's right. Yeah. And so some surgeons use absorbable sutures, but I tend to use non-absorbable type sutures that, if they're correctly placed and you do the surgery correctly, you shouldn't get hard or sharp lumpiness within the penis when you've corrected it. So if you do get that, those sutures can be removed if they're causing problems, but they often end up smoothing out. So they end up like little sort of ripples rather than being sharp, sort of jagged sutures sticking out like nylon threads. And shortening, yes, shortening's the big one, because if the bend is really bad, then application can't do it all on its own. You end up taking too much to straighten it again. So that's when I talk to patients about expectations and what they want and what I need to do. And then it comes down to a discussion between us and them, between, surgeon and patient about, what they would be satisfied with afterwards in terms of function, because that's the critical thing.
Yeah. And sometimes you just need to put in a prosthesis.
Yeah, well, that's right. Sometimes it's a case of we can fix it, but you'll end up with a very short penis, or we can put in a prosthesis and then we can allow the prosthesis to keep your length that you have. So, and sometimes they agree to that because it actually is achieving all the aims that they need.
Yeah.
So.
All right. Well, I think we've covered most things to do with Peyronie's disease and penile curvature, but are there any other things you think we should have covered, Eddie?
Just thinking, the only other question I would have is, we talked about that medication. I can't remember the name of the medication, the flesh-eating medication, and how expensive it was. So, the kind of procedures you were talking about, Shane, are these kind of procedures that would ordinarily be covered by, someone's health fund, in terms of actually just getting some sort of gauge in the cost? Because, you mentioned that, that sort of, those procedures, that medication was about $40,000.
Yeah, they are. So even though patients sometimes think that this type of surgery is cosmetic, it doesn't actually come in under cosmetic. It is covered by Medicare.
Okay.
So it is funded. So it can be done in the public or the private hospitals. Okay. Unfortunately, in the public hospital system, it's low priority because it's not cancer, it's not urgent surgery.
Yeah.
So it tends not to be done very often. But in the private system, it's readily available. Health funds will cover the hospital costs, and Medicare has an item number for most of the procedures that we do. One thing to think about with the Xiaflex was, even though it is expensive, there's no reason why patients can't appeal to their health fund with respect to special assistance to purchase it. And it's something that it does sometimes occur in terms of drugs and medication for some patients who've reached their limits, both through Medicare as well as through their health fund providing it. But it's not very often that they get the opportunity to do that.
So maybe I can summarise just by saying that this is a condition which is fairly common, probably more common than we think. It can really affect men and their partners, and the take-home message is that there are treatments available and they need to be tailored to each patient's situation and what their expectations are and what their goals of treatment are. But it's an ever-evolving field, isn't it, Shane? I mean, it's certainly from when I started practice seems to be, becoming a lot more nuanced and a lot more sophisticated in the way it's treated.
Absolutely.
Yeah. So what would your sort of take-home messages be to patients who are listening?
I think the most important thing is if you think there's a problem with the shape of your penis and you don't know if it's something that you need to have assessed, then talk to your doctor and get referred through to a urologist, because we know that treating this disease process early gives you the best chance of dealing with it, and delaying treatment until such time as you've got severe deformity sort of limits your options a bit. And there is a percentage of patients who will respond quite well to those early treatments being instituted. And it's not just surgery, but that is available to those who need it. But early treatment's really important. And don't be embarrassed about it. It's it's no worse than any other condition of function. Women who, for example, have breastfed, whose breast volume has decreased, and they're really uncomfortable with the fact that they used to have nice boobs, and then after breastfeeding they don't. For them it's a natural thing to think about having a breast implant procedure because it's so accepted, and women talk about it. And guys need to probably just take the same approach with something that's very personal and speak to their doctor and just say, look, is this normal?
That's great. Well, look, thanks very much, guys, for agreeing to talk about a touchy subject, and one which is, I think this type of podcast is going to be very, very valuable to patients out there who are concerned or embarrassed or worried about what's going on down below. So, look, thanks very much. And if you think of any questions or any things that we should have covered, we can always add them in later as an additional bit of audio. But
Postscript,
post-production.
Postscript.
But for now, I say thank you, and we'll sign off. Cheers, guys.
Cheers. Thank you.
Cheers. Thanks very much.
This podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed by listening to this podcast. The use of this information and the materials that link to this podcast are at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice. Anyone listening to this podcast with a medical condition should seek individual medical advice and should not use this podcast to delay treatment or disregard the information given to them by their health professional for treatment of their condition. The information used in this podcast should not be used as a substitute for expert medical opinion in any medico-legal proceedings.